Test 1 2 1 2 test. Testing 1 2. Test 1 2 3 4. Okay. Okay, so you want me to try to send you that one, or?
Yes, if it'll let you open it and save it as a PowerPoint and then send it to me. 'Cause it's not letting me do it.
You gotta put up there just restrictions. Everything needs to be emailable. If you're gonna do a PDF, it needs to be one slide per page.
Yeah.
Give them some restrictions.
A bit easier starting off January, New Year.
We could go through December and kind of go through all that stuff, you know. I mean, even things like make sure you wear something that's either got a lapel or something on it so we can clip a mic.
You know.
Tell me when. Okay, go ahead. Okay, so I'm Kathy Harrington, and I'm an epidemiologist and health behaviorist from UAB in the Pulmonary Division, and I'm going to talk to you about vaping. And I hope this is a clicker that works. So I have no financial disclosures or relationships to disclose. However, I will disclose one sort of for total disclosure. It's weird giving a lecture without an audience. So I will do my best. So the objectives today, what I really want to talk about is what are vape devices, what's the nomenclature, what do they look like, who's using them, what are the risks associated with them, including EVALI and now COVID-19, and what's your role as a healthcare provider in terms of your patients. So, what does vaping look like? I think we've all seen it. We see clouds of smoke coming out of car windows or walking down the street. It's once you recognize it, it is so different from typical combustible cigarettes in terms of the amount of vapor cloud or smoke cloud that you would see. So, just very briefly, you know, they started back in 2003. They really weren't introduced to the United States till 2007, but we didn't see a big uptick until about 2014. And I'll talk a little bit more about that later. Anyway, it's basically supposed to have been developed to mimic a cigarette, but with a vapor instead of a combustible smoke. I'll talk about the ingredients, but just let's talk about the nomenclature. They are called so many things, and I can't tell you how often when I ask, do you use tobacco, I get a no, but then if I ask, do you vape, I get a yes. So when I proceed to say, well, are you using a juice with or without nicotine, they don't know, or yes, it's got nicotine. So the reason I bring this up is because when we typically ask about tobacco, which we do, in the healthcare setting all the time, our patients don't always recognize that vaping is a part of that. So a lot of people call them ENDS, electronic nicotine delivery systems, e-cigarettes. I'm sure you've heard that term probably most often. There are also electronic cigars now, or e-cigars, e-hookahs and hookah pens, vaping devices, vapes, vape pens, personal vaporizers, mods, and tanks. So I've got sort of some pictures at the bottom of this particular slide, and I think you can appreciate that they all look a little bit different. Now, some of you may recognize some of these, and you may not. Does anybody have an idea of why it has become so popular in recent years? Well, I have to tell you the answer because you're not here to answer me, and that is because they've become very easy to get. Juul, which came onto the market a few years back and had really dominated the market, has something that when I first saw it, I thought it was a USB device, and that's what they look like, and most parents don't know that, so it's easier for kids to get away with it. The other interesting thing about vaping is that it doesn't smell like you're smoking. So the odor, there's no odor like what we're used to. So anyway, so let's talk a little bit about the e-juice because that's really the main thing. So it's got nicotine, varying levels, and there are nicotine-free, but most of what you purchase has nicotine. There's carrier solutions, which are typically propylene glycol or vegetable glycerin, and then flavorings, tobacco, menthol, cinnamon, candy, fruit, wine, tiramisu. What's your favorite dessert? We have it. And that has really become more popular with Juul as they prepackage them like that. But you can get these anywhere. So just to show you, if you look at nicotine flavor, and this was between, sorry, my slide has an error here, between September of 2014 and May of 2020, you can see a big change. And what you'll notice is a big increase in mint as a flavor and other flavorings. Now you see that the tobacco, which is the top blue line, the top portion of those, that tobacco flavor has stayed essentially the same. It's other flavors that have changed. Okay, guess what? Now, we're not going to see in the pre-packaged e-juice container, so something you'd get like with Juul or an e-cigarette where the juice is already part of the device. No more are we going to be able to see these flavors like cinnamon, candy, fruit, wine, whatever, as of January 2020. So that's brand new. Up until then, you could get any of them. Now you can still get those flavors if you buy your own juice or mix your own juice. Okay, so let's talk a little bit what's in this. So first of all, with nicotine, they're labeled, but when people have looked in labs at the amount of nicotine versus the amount of nicotine that it's labeled, it frequently doesn't match. So what they're finding is there's usually more nicotine than what's advertised. And then how much does each puff deliver? So you think about it, with a cigarette, you take a puff, you put it down. With a vaping device, most people who are really serious vapors will kind of keep the device closer to their mouth, and they'll do a series of puffs. And so there's something we call puff topography, and that has to do with how deeply you inhale, how long you hold it, how large of a puff basically you take. And each puff you can get between 0 and 35 UGs. Help me somebody. Anyway, nicotine, it's how they measure it. And it is very different according to the product and according to the battery and according to the person's puffing topography. All right, so the carrier solutions, propylene, glycol, and vegetable glycerin, they're toxic to lung cells, and the greater the dose, the greater the toxicity. No surprise there. And flavorings. So interestingly, flavorings really influence satisfaction. You can imagine, personally, I'm not a vapor, but I have heard people tell me that instead of eating a dessert when they're on a diet, they will just puff their dessert and get the flavor that way. But also health effects. We know that, for instance, butter flavor can result in popcorn lung, which is a disease of the lung we used to see in people in popcorn factories. And then it actually is from the butter, I believe. And then there is cherry, I know, is supposed to have a very negative effect on the lungs. So different flavorings can have a different impact. So toxins, carcinogens, and particulates. Well, we hear about this with cigarettes all the time, don't we? And the biggest thing that we know about is what we get, or what we get from the burn, or the side effects of the smoke. We don't have that with e-cigarettes. However, with that vapor, we still get a certain amount of other particles. The particulates are a little bit different than they are for cigarettes. They're on a lower magnitude, which is good. However, the higher the nicotine content, the higher particulate content in the vapor. And the particulate size is a little bit different. I've got a slide later that'll show you this a little bit more, but it's a little bit different than what we commonly see in cigarettes. It's spread out across a larger spectrum. And we also know that some of these particulates are known to cause diseases because it's what we know from tobacco smoke. In terms of what that impact is from vapor, we don't know yet. Those long-term effects are still unknown, and that's being studied now, and it'll take a while to find out. Okay, so I want to talk about who is most likely to be vaping. So among adults, and by adults we mean 18 and over, although some studies include 21 and over. This particular one, I believe, was 18 and over. We see that if you'll look at this chart right here, the light blue is ever use. That means they've tried it ever in their lives, and the dark blue is current use, which means last 30 days use on all or some days. So we see that more men than women. We see younger more likely than we do older, and it decreases a lot with age. We see that that non-Hispanic whites are the most common users, although we see all the other Hispanic, non-Hispanic blacks and Asians typically between 10 and 12% for ever use, and between 2 and 4% for current use. And then among income, just like we do with tobacco smoke, we see higher use in lower income than we do in higher income. Although, if you look for current use, it's not terribly different. All right, so by smoking status, so here's this slide is from 2018. I have seen things that are a little bit different from this in terms of this one suggests that most of the e-cigarette use is among former smokers who quit during the past year or quit in the past 1 to 4 years. What I'm seeing in my practice at UAB is more dual use. About 85% of people that vape that I see are also still using traditional combustible cigarettes. So why do people like vaping? Well, lots of reasons. I'm sure if you've seen any ads for it, or if you ask somebody on the street about it, what they'll tell you is it's safer. They'll tell you it's cheaper. They'll tell you it's better for you. There are lots of different reasons, but I think in general the population has the idea that it's safe. And but there's also satisfaction. So if you ask somebody who's using it now among adults, they'll say the throat hit. So when you talk to a smoker who's got an urge to smoke, they'll tell you that that urge is really ended, not before the nicotine, before the nicotine gets in their blood. It ends when they get that harsh hit at the back of their throat. And I know that some of the companies that were developing the juice for electronic cigarettes tried to add different kinds of acids, like citrus acid, to the juice to see if it would increase the harshness of the throat hit so it would be more satisfying to smokers. So, relief of the urge to smoke, again, associated with a throat hit, but also they do get nicotine at a much, much slower rate than with a traditional cigarette. The mouthpiece fit, how comfortable it is, especially those that kind of hang it off the side of their mouth. The draw resistance, how hard it is to draw, and then the vapor cloud. Now that has changed a little bit. This data is from 2018 and before, and now we're finding that the vapor cloud is not as interesting to folks as it used to be. And then refillable devices are generally rated higher for satisfaction than cigarette lookalikes. And the reason for that appears to be that when it's refillable, you can set your own nicotine level, your flavor level. You can set, most of the refillable cartridges fit into tanks or mods where you can have stronger batteries and get a much bigger hit of nicotine and everything else with those. So let's talk about youth. So if you've been watching the news, you know that this is our big problem right now in the United States. And that is because what we're seeing is that youth are starting to adopt tobacco through vaping. So in middle school, this is based on 2019, which is our most current data, we see about 10.5% have used an electronic cigarette in the last 30 days or vaped in the last 30 days on some or most days or all days. About 2.3% cigarettes. So if you look at the all tobacco use, what you see is there's maybe a little overlap, but not a tremendous amount. And then you get to high school, and it's an astounding almost 28% are current users. Now, about 5.8% are cigarette smokers, and then 31.2% are tobacco users. Almost a third of our youth, this is high schoolers, so we're talking 14 to 18 or 19, are vaping. Almost a third on a regular basis. Now, I recently was with a couple of college students, and I asked them, they go to a very academic institution, and I thought, well, we're going to have a higher SES here, we're going to have some really bright kids. I said, when you go to a party, how many people at the party would you say vape? They said, 80%. So it is very much a social thing among youth, and we know what that's like with alcohol, so it's not a huge surprise. What's really scary, though, is between 2017 and 2019, we saw a 67% increase in current use of vaping among high school students. That's a tremendous increase. So what does that mean in terms of health and the big picture? Oh, one more thing. So this is advertising. These are actual advertisements for vaping. So these are some of the flavors you can get. You can imagine who some of these are aimed at. They're clearly not aimed at adults, I don't think. I don't think gummy bears and gumballs, but I don't know. But look at the beer and the gin and tonic. So the advertising is very targeted. And 68% of high school students said they only use flavored electronic cigarettes or vapes. So this is youth trends from 2011 to 2019. You can see the startling rise. We went from back in 2014 where we really saw it begin. It's more than doubled. So that's in 6 years, it's more than doubled, and it's continuing to increase. So why is it a concern for youth? Well, adolescent brains are still developing. Nicotine impacts how the brain works. So what we've seen is that youth that vape tend to have an increased risk for other addictions, for impulsivity and mood disorders that carry on beyond adolescence. So that's a big concern. Is this something that can impact the rest of their lives? And then they have a much greater chance of finally using combustible cigarettes, especially when flavor use is first. In fact, a study that they've done nationally shows that about 7 times the risk of smoking a combustible cigarette 6 months later if they vaped by the time they were in the 9th grade. So you have somebody entering freshman year of high school, chances are that they're going to move on to a combustible cigarette, and we all know the harm of that type of tobacco. So what about secondhand vapor? I was asked about this about 7 or 8 years ago. Somebody called me from a magazine and asked me what I thought about it, and I said, honestly, I don't know. I said, I have no idea, but I will tell you, I wouldn't stand next to somebody who is vaping. But I couldn't tell you really why, other than just instinctively. Well, we know there's no side stream smoke. So that's good, right? That's a good thing. But there is exposure from the inhaled vapor. For instance, you get the nicotine. If you go into an enclosed space with somebody who's vaping, like a small room, or you're in a bar and everyone's vaping, although that's typically not allowed. But you will, in fact, get some buzz effect from the nicotine. We know the toxins are a much lower level than it would be if you're standing next to a smoker, and that we find that the serum cotinine levels are similar for secondhand vape as they are for typical cigarettes, or a little bit less, depending on which study you look at. As vaping has increased the amount of nicotine available through most of the products and the juice that's available now, we see that rate has gone up in terms of the cotinine level, which is a marker for nicotine. So this is what I referred to, I was going to show you later, and this shows you the particulate size for vapor versus cigarettes. It's a little bit hard to see, and I don't have a pointer. Can I point to the slides with this? Can I point to the slides with this?
You can touch the screen.
Oh, I can touch the screen. Okay, so here you can see this is typical particulate matter for cigarettes. That's the size. You can see with these 4 different types of e-cigarette juice, vapor, they're all over the map. So we do have a great variety in particulate size, and the main point is that's still there. What does particulate do? It causes inflammation in the lung. Okay, so health effects. Well, the long-term effects are unknown at this time. As I mentioned before, those studies are being done, but we really don't know. However, the health effects that have been identified is there are some systemic effects. Oxidative stress is increased, inflammation is increased. In fact, they did a study where they looked at the lung inflammation in response to a puff from a cigarette versus an inhalation of vapor, and they found the inflammation level was about the same. Inflammatory response was the same. Infections, greater likelihood of pneumonia or other lung infections, dysregulation of the repair or extracellular matrix remodeling, immunity is reduced. We know that your immune system is reduced when you smoke. Same thing with vaping. Of course, we've seen nicotine poisoning in children. This is accidental. I think we're seeing a little less of that now that more of the cartridges are being used. And then mechanical injury from battery explosion, which is also not common, but still a risk factor. So this is just one thing looking at blood vessel impact and oxidative stress, whether you're a smoker or not a smoker. You can see before and after vaping that there is a change, and it's negative. So, EVALI. So this is e-cigarette or vaping product associated lung injury. I think a lot of us have heard about recent cases of some deaths, and I believe there has been about 36,000 reported at the ER, and there's been about 60 deaths nationally in the United States that are related to this. So it's a diagnosis done by exclusion. So you see infiltrates on the pulmonary scans. You have a history of vaping in the last 90 days, particularly with THC, which the vaping devices are being used a lot to deliver the marijuana impact, and or nicotine, and sometimes both. And there's no other known cause. So it's kind of like we've ruled out everything else. This is what we've come up with. They believe it's the vitamin E acetate that's the main ingredient in the juice that's causing the problem. And it's primarily seen in 18 to 24-year-old males, which should not be a surprise since that's probably one of the highest groups using or vaping at this time. So, vaping and COVID-19 risk. So I was particularly asked to address this. So there has been a fair amount in the literature about smoking and COVID-19 risk. Now, it's not a surprise to anyone that if your immune system is compromised, which it is from tobacco use, that you're going to have a greater risk of acquiring COVID-19, and that is true. And there's some various reasons why this happens, having to do with some of the chemokines that are upregulated. We also see that young adults are 5 times more likely to receive a positive COVID diagnosis if they've ever vaped, and if they've recently vaped, it's even higher. And so there's a suspected increase in the ACE2 from nicotine that is allowing the coronavirus access in the lungs. So I found this a particularly helpful schematic that shows why being a smoker, and this particular article that I drew this from refers to smokers and vapors equally, that they believe that the evidence is the same for both of them. So you've got impaired clearance, you can imagine, increased permeability, more ACE2, so there's more access of the virus to the lungs, and then an easier spread hyperinflammation, and you end up with cytokine storm. So that would help explain why vaping are not just more likely to get, vapors are not just more likely to get COVID-19, vaping on health are determined by many things. So one of them is the e-cigarette brand, because different brands have different things in their juice. They've got more of some things, less of others. There's no federal regulation at this time for what's in the juice. So, and we know from lab experiments, in fact, some we did at UAB in the Lung Health Center, they found that what was listed on the website or from the company didn't always match what they actually found in the juice. The type of device, we know that the more powerful the battery, the more of a hit you're going to get, the more of the particles you're going to get, and more impact. Flavor additives, the flavors make a difference. User puffer padding, influenced by nicotine content. So those with greater nicotine content tend to puff a little bit less, but that's not always the case. And then battery voltage, which I mentioned earlier. So potential health gains. I want to give you a kind of balanced portrayal here, so that if this particular report was assuming that traditional cigarettes were replaced by electronic cigarettes or vaping devices over a 10-year period, between 1.6 and 6.6 million deaths avoided, a lot of life years saved, For youth, life expectancy would be by a half a year. And I just want to remind people that among smokers, we say the average life expectancy is shortened by about 10 years. So they're not showing a big difference here when they say it would only be a half a year gain. And then among switchers smokers who switch, there's a reduction in blood pressure, lung function, and disease symptoms, particularly asthma and COPD, and improved mood and memory. Again, this is based on a couple of different studies, and this is hypothetical. Now, the odds of everyone who smokes switching to vaping are not great, number one. Number two, we have a whole new generation of vapors who are not traditional smokers yet. So this is an unlikely scenario, but I wanted to present it just to show what the difference is in terms of it would be better. So, does vaping help to quit smoking? The evidence is very mixed. More robust studies are needed. Quite honestly, the studies that have been done are with very small numbers. They've got small effect sizes, and they're usually comparing it to traditional smoking cessation methodology, such as nicotine patches or one of the prescribed pharmaceuticals. And then high quality studies are needed. They're just not as good as they need to be to really come up with a good answer. Now, Dr. Glantz did a meta-analysis of 11 studies that had been done. Now, these are early on, and so this is when e-cigarettes were not as advanced in terms of technology and type as they are now. So this is kind of based on the old technology where the nicotine content was probably a little bit lower. And she felt a small effect, a relatively small effect that it would help with quitting smoking. So what are the public health concerns? Well, we've got quite a few. So the biggest one is the future addiction to nicotine. And that's for both non-smokers and former smokers. So think about somebody who quit smoking and decided they've missed it. They've been tobacco-free maybe for several years, and they're going back and starting to vape. What we found is it pretty much reacquaints them with nicotine addiction, and they find the vaping eventually leads back to combustible cigarettes. And then the other thing is, and I think this has already happened, is that vaping is pretty glamorized. If you look at some of the ads for it, it looks pretty glamorous. They tend to show pretty cool people supposedly vaping. It's become renormalized. So tobacco use is renormalized, particularly among our youth and young adults. It's not been effective, and it is not approved by the FDA as a smoking cessation device. And so I think that I would caution, and I'll mention this again, I would caution you not to use it or not to advise it as a smoking cessation device. And it can maintain smoking. So though someone who, and I see this a lot in my patients at UAB, is that they are dual users, that they start vaping because they think it's going to help them quit their combustible cigarette use, and what happens is they do both, and they don't really give either one up, and sometimes it actually increases their nicotine addiction because they're getting more nicotine from two sources. The risk of injury from battery explosions is pretty minimal now, but it's still there, and then the e-cigarette solution poisoning, which really is an issue with our pediatric population. So the FDA has a deeming rule that, in fact, starting in 2016, they have authority over these electronic nicotine delivery systems. So they are going to have improved quality control and standards that have to be adhered to. Everything before this has been grandfathered in. So that's going to be for future products. They're up until this year, they could sell to anyone 18 or over. Now they have to be 21 and over. So that is, at least in terms of sales in stores, that's a difference. Health warning labels. So they've had to, They will have to have health warning labels that they contain nicotine, which is a tobacco product, no vending machine sales, no marketing implying healthy or safe. Well, I bet that's a surprise to some of you because almost everyone I ask says, oh, but they are healthier, they are safer. So they can use the word safer, they can't say safe. And that's a big difference, but the implied message is it's safe to use them. The grandfather period for products was supposed to end March of 2018. They extended it to 2020, but they have had an amendment to this where as of January of this year, no pre-filled cartridges can contain anything other than tobacco or menthol flavors, and no more advertising targeting youth. So that's new, and we should see the impact of that soon. So what are the key points I want to say about electronic cigarette and vaping? They are tobacco products most of the time. The youth who vape are more likely to progress to traditional cigarettes. Juice and aerosol contain toxins, including nicotine, but other toxins that we really don't know the long-term effects on the lung. Some studies I've seen with cigarettes show that it's not the amount that you smoke, but rather the duration that you smoke that impacts the likelihood of developing COPD or lung cancer in the future. With that in mind, it may be that the lower toxins are still going to have an impact with duration. We just don't know. It does have negative health effects compared to no smoking. The short-term health effects, other than EVALI and COVID-19 and reduced immunity to the flu and other things like that, appear to be fairly similar to smoking, but the long-term effects, again, we just don't know. And then very mixed reports about smoking cessation. So it's a dilemma for those of us in public health. What do? We don't want people to smoke. We already know how bad that is. So what do we do? And I have been asked today, in fact, whether I thought it would be better for someone to smoke or better for someone to vape. Personally, as a health behaviorist, I can tell you it is very hard for someone to quit tobacco. It is an addiction not just from the nicotine, which is a biological addiction. There is also a behavioral addiction, and it's a hand-to-mouth addiction, albeit differently for vaping versus cigarettes. But changing that behavior is part of quitting tobacco use, whether it's vaping or traditional cigarettes. Personally, I think because the data is out on long-term effects, I would not advise either one. I would particularly suggest anyone that vapes to reduce the amount of nicotine over time and go to a nicotine-free and then nothing. So that you get rid of the biological effect first, but would never recommend either one. So, what do the public health experts say? We've got a seesaw going on here. We've got people that are harm reduction. It's better, it's less harm. But then we also have they aren't safe, they maintain and promote a nicotine addiction. You know, I think it's pretty clear which side I'm coming down on, but I wanted you to know that there are arguments going both ways. So, what can you do in clinical practice? So, one interesting thing is, and I think I mentioned this already, that when you ask if somebody uses tobacco, they don't always think vaping is tobacco. So you need to be specific. When you're assessing tobacco use, most people will say, do you smoke? What we really need to be saying is, do you smoke or use other tobacco products, including vaping or e-cigarettes? I think most people who vape recognize both those terms. We need to be very specific because we find that not everyone will admit to it, and therefore you'll overlook a potential opportunity to give them some health advice. I would advise both youth and adults about the harms of vaping. I would advise parents of children not to vape, and I'd also, for parents of young children particularly, to be cautious about if they have non-self-containing cartridges, that they are very careful where they store their juice. So for adults, assess their vaping when you ask about tobacco. advise no tobacco products and refer them to tobacco cessation services. And then, and I'm going to talk about that in a minute, but assist with additional pharmacotherapy to aid a quit attempt. And at the end, I have a slide that shows you the most common pharmacotherapy available. Some of it's over the counter, some of it's prescription. I do know that when you write a prescription for the over the counter, sometimes insurance policies will cover it, which is one reason to do it. The other is to make the point about that this can help you. So one of the issues we have here in Birmingham and in Alabama is that we have very limited access to tobacco cessation services. But we do have, in every state in the union, we have access to a quit line. And the Alabama quit line will offer, and you can refer, so the first thing you can do is you can give the patient the number. It's 1-800-QUIT-NOW, so it's pretty simple. But we find that patients tend not to call it. You can do a fax referral, or you can do a warm handoff if you have that ability in your practice to actually call them and put the patient on the phone. So what they have to do is sign up themselves. Now, when they sign up, they get 5 counseling sessions over the phone that they can schedule with a nationally certified tobacco cessation counselor. They can also get anywhere from 2 to 8 weeks of free nicotine patches and gum, but they have to sign up for the counseling to get that. So it's 1-800-QUIT-NOW, and it actually is a very good service. They use motivational interviewing counselors, and it's something that's available to everyone at no cost. The other thing you can do is you can contact them through the Alabama State Department of Health, and they have brochures that are helpful for people to help quit smoking, and they also have cards with the number and what their services are that you can give to patients. So I've recently gotten some of those. It takes a little while, but you can get those, and that's helpful. So this is the pharmacotherapy, and I would recommend that you ask the patient what they've used before. If they think pharmacotherapy is something that would help them. There are some differences. So if you have bupropion, which is also called Zyban, is used for depression as well, and that's in fact what it was originally used for, and they discovered that, gosh, a lot of these patients were able to quit smoking while they were on this medication. So if you've got patients who have a tendency towards depression, or when they've quit before, that's been a big problem, this might be something for them. Varenicline, which tends to be very expensive, but a lot of insurance covers it now, called Chantix. I think most people are familiar with that name. You would start them off on different doses and work up, and they would also smoke the first few days, so maybe set a quit date down the line. And then nicotine patch, nicotine gum, nicotine inhaler, and now nicotine lozenges have suddenly become a lot more popular. And I think all but the inhaler are over the counter now. But writing a prescription, again, like I said, and that my understanding is for Medicaid, they're no longer counting this as one of the core prescriptions against them, so that if they have other medications, this would be able to be on top of that. The other thing is, we know that just by a healthcare practitioner advising someone to stop smoking or vaping, that it has an impact. It increases, almost doubles the rate of just quitting on your, just quitting. About 5% will quit on their own, and about another 5% if they're advised by a healthcare professional. As a certified counselor for tobacco cessation, I will tell you that if you can relate it to their health, specifically to them, not just in general, but specifically to their health or their risk for health outcomes, that you'll have a greater impact. So especially right now with COVID, and with us knowing so little about COVID, more is being discovered by the day. Initially, we didn't think that smoking and vaping had that big an impact, but recent evidence in the literature is suggesting it has a greater impact than we thought. So I would recommend for any patient who is vaping or smoking that you would discuss with them their increased risk for acquiring COVID and their increased risk for having a bad outcome. Okay? I think that's all I have to tell you. I do hope that you will encourage anyone, you know, particularly youth and young adults who seem to be the most likely to vape, that they reconsider that decision. Thank you.
Can I start?
There we go.
Okay, good afternoon, everyone. My name's Gilbert Perry. I'm a professor of medicine in the Division of Cardiovascular Disease and Vice Director of Clinical Services at the University of Alabama in Birmingham. And I've been asked to talk to you today about cardiovascular manifestations of COVID-19. So this will be a cardiologist's take on COVID-19. What I thought I would do today is briefly give you some information on the pathophysiology and epidemiology of COVID-19, both worldwide and also here in Alabama. And then spend most of the talk discussing acute cardiovascular manifestations of the COVID-19 disease, especially with regards to myocardial injury. And then toward the end, we'll briefly talk about arrhythmias, thrombosis, and some of the meds that may be implicated with COVID-19. So as you're all aware by now, COVID-19 is caused by the SARS-CoV-2 virus, which is a single-strand RNA. That virus binds to receptors, ACE2 receptors, that are expressed on the cells of multiple organs throughout the body, most importantly the lung and respiratory tract, but also the kidneys, bowels, and for today's talk, importantly, myocardium. The virus spreads primarily through respiratory droplets and airborne particles, but hand-to-mouth transmission is also possible. And you may be aware that RNA has been shown to persist for up to days on surfaces after exposure, although whether this is live virus and the clinical importance of detecting RNA on surfaces is uncertain. Live virus has been isolated from fecal specimens, so oral fecal transmission is possible. And you may have seen the CDC has recently updated its guidance on the respiratory airborne particles, and also kind of expanded the risk in the sense that 6 feet is no longer necessarily safe. These airborne particles go a lot further than that and may be a more important cause of spread than was previously appreciated. Infected individuals are contagious prior to symptom onset, which is the reason this virus has created so much havoc in this country. So infection risk, the likelihood of spreading it starts 2 to 3 days before you're feeling bad, peaks about half a day before symptom onset, and then declines within 7 days. And generally speaking, if you're afebrile and 10 days out from the onset if you're asymptomatic and 10 days out from the onset of the symptoms, you likely are no longer contagious. Worldwide, through the end of September, there was over 32 million cases and over 1 million deaths. Just in the week of September 7th to 13th, when I was putting these slides together, there were 1.8 million cases that week and 40,000 deaths that week worldwide. In Alabama, through the third week in September, we had 150,000 cases and just short of 2,500 deaths. And by now we're over 2,500 deaths. If you look at hospitalizations, there's a little glimmer of good news for us here in Alabama. So the confirmed hospitalizations have been tracking down since they peaked in the summer. And despite starting school back, we have not seen an uptick, at least in hospitalizations, either in the 7-day average or overall. If you look on the bottom right of this slide, the green bars there showing the RT, which is the number of people who are infected for each case. So if that's below 1, it means that the virus load in the state is not increasing. It's 0.92 on the slide. Actually, if you go to Bama Tracker today, it's 0.94, so it's creeping up. We'll need to keep an eye on that. In terms of where COVID is in this state, Jefferson County is right in the center there. And you can see we have the most people, and so we have the most infections. The other two places that have the most infections numerically are the Mobile area and up near Huntsville, so where all the people are. And that's true in the 7-day average as well. However, if you look at the total cases per 100,000, that tells a different story. So here, the hotspots are not the big population centers, it's actually the rural areas of the state. And you can see up in this area, in the northwest corner of the state, there's 5,000 cases per 100,000, new cases 30 per 100,000, which is really quite significant and concerning. And you can see other rural areas as well, for instance, Chilton County. Some of this isn't surprising. I went down to Chilton County when this thing, a few months after this started, to pick strawberries, and I think I was the only one in the entire Chilton County wearing a mask. So some of these things, unfortunately, are really spreading in the rural areas. If you look at hotspots in Alabama right now, again, percent positive in the last 14 days are these rural areas, Chilton, Franklin County, Clay County. And what's particularly concerning is that the percentage of positive tests is also very high. So 20% positive tests in Franklin, 20% in Chilton, 30% here in Clay County. So when you see a combination of high positive tests and high cases per 100,000, that means we're not really testing enough, and the epidemic is actually much worse in those counties even than we realize. So we're only testing symptomatic patients there. Overall, if you look at the outcomes, the deaths, in the United States, there have been over 200,000 deaths since the epidemic started, and 62 per 100,000. So that's one of the highest numbers in the world, it turns out. It's fairly high for a industrialized country. The case fatality ratio, the case fatality ratio is the cases that are diagnosed, how many of those die. And the gross case fatality ratio in the United States is about 2.8%. In Alabama, it's a little better, it's 1.6%. The actual mortality from this disease is going to be less than that because many people who are mildly symptomatic or asymptomatic never get tested. So if you test positive and get tested, especially for symptoms, the case fatality ratio is 2.86% gross. And you can see that Alabama, compared to other states, actually in the southeast particularly, does reasonably well. So who dies from COVID? Underlying cardiovascular disease is a huge risk factor for having severe COVID, ending up in the ICU and dying. It turns out that the most important risk factors are age, BMI, so being overweight, especially morbidly obese, and sex. So men tend to get worse cases than women. CV risk factors are also important, and you can see that down in this part of the slide. Hypertension, hyperlipidemia, heart failure are all important risk factors for bad outcomes, but you can see, for example, that age is much bigger risk factor, as is being morbidly obese. Interestingly, in this population, so this particular study was Kaiser Permanente, almost 7,000 patients, so by definition they're all insured. Also, because it's an insurance company, in addition to being a HMO, they have a lot of information on these people with regards to income, where they live, what they do. So it turns out that race, ethnicity, and socioeconomic status are actually not risk factors for bad outcomes in COVID once you account for age, BMI, sex, and other cardiovascular underlying disease. So it's not the ethnicity, it's not even socioeconomic class, at least in this population where everybody's insured, it's the underlying risk factors. Now, in Alabama, where we have all these uninsured patients, probably socioeconomic class would have a different impact. If you look particularly here at the BMI, you can see that in men less than age 60, who normally should have a pretty good prognosis, if you were in the morbidly obese range here, like BMI over 40, the risk is increased tenfold, and this is even worse in the men. So this is overall, and this is in the men. So young men who are overweight, the risk is as bad as if you were much older. In terms of cardiovascular complications specifically, there are various ways of dividing these up. One way would be to look at primary versus secondary cardiac involvement. So in that scenario, primary involvement would be an acute coronary syndrome, so you have a heart attack. Myocarditis would be another primary cardiac involvement. Arrhythmia might be a primary cardiac involvement or might be secondary. Secondary acute cardiac involvement might be from myocardial injury of one sort or another, from cytokines, microvascular dysfunction, or arrhythmia. and heart failure, either exacerbation of pre-existing heart failure, new onset heart failure. And the heart failure in COVID can involve either the left or the right ventricle. Finally, other cardiovascular complications include a prothrombotic state, an increased risk of thrombus and pulmonary embolism. And there's also, we'll talk briefly at the end of whether there may be a long-term subacute risk from COVID. So to begin, we need to talk about some definitions. Myocardial injury is defined as having a cardiac troponin more than 99th percentile upper limits of normal. And it turns out myocardial injury is fairly common in hospitalized patients with COVID-19. The troponin elevation is usually mild, but it can be quite severe, and in either case has prognostic implications. So it turns out that the prevalence and the magnitude of the troponin elevation is very variable depending on what assay is used, the prevalence of underlying cardiovascular disease, and how sick your patient is or population is. So this is a bubble slide I created trying to collate data from a wide variety of studies around the world. I didn't put the references on here. You can see that most of these studies are out of Wuhan, China, and I've just labeled those Wuhan 1 through 7. Then there's a big study out of Mount Sinai that's in the middle there, and then a very small study out of the Seattle ICU. And these studies had widely varying prevalences of troponin elevation, but as I'm trying to show you on this slide, that's related to the different assays that were used and the different cut points for what they used. So on the x-axis here, I've plotted the troponin I cut point that was used, considered abnormal in the study. And depending on what assay you use in your medical center, for example, if you have one of the older assays that uses a cutoff of 0.03, that would be the same as 30 picograms per ml on the slide we're looking at here. So 0.03 on the old scale, if you have a new high sensitivity troponin, is 30. So what you can see is it's, except for that study labeled Wuhan 3 that I've outlined with black on the bottom there, the other studies, more or less, there's a linear relationship between the troponin cutoff and the prevalence of abnormal troponin. So Wuhan 4 in the upper left, the cutoff they used was about 15 picograms per ml. So again, on the older assay, we can't even detect that. That's less than 0.01. So very, very low level. It turns out that if you use a cutoff that's highly sensitive like that, that 40% of your patients are going to be positive. On the other hand, if you look on the bottom right of the slide, the study labeled Seattle ICU, you can see they used a very insensitive troponin with a cutoff of 60, that's 0.06 on the old scale, and they only saw 15% despite the fact those were all hospitalized patients in the ICU. The size of the bubble indicates the number of patients in the study, and you see the biggest study by far is the Mount Sinai study, and we'll talk a little bit more in detail about that in a moment. Now the outlier here is Wuhan 3, which is outlined in black. You can see that seems to be off the scale a little bit. It turns out if you break that study down and look at the patients who were in the ICU there, they fall right on a line with everybody else, but most of the patients in that study were on the wards and apparently weren't very sick, and that likely explains why they saw a lower prevalence. The study labeled Wuhan 6 similarly had patients that, by reading the paper, didn't sound like they were all that sick, and the same thing with Wuhan 7. So there, if you break that down, it turns out that 8 of the 8 ICU patients were troponin positive versus 1 out of 26 of the floor patients. So in summary, if you have a sicker population, you're going to see more of this, but if you kind of take your average hospitalized population, the main driver, the percentage of abnormals, is what the cut point is. So it doesn't matter. Do people who have an elevated troponin do worse? Well, they do. So this is a different study out of China, 416 patients in January, February 2020. In that particular study, they used troponin T, or the slide previously was all troponin I. Using this fairly sensitive cutoff of 9 picograms for troponin T, 20% had injury, and you can see the outcomes were much worse in the patients with positive troponin than in those without. A mortality hazard ratio of 3.41. This is the Mount Sinai, which was that big bubble in the middle of that slide. So that cohort was 2,700 patients, median age 63. They were admitted February to April, and if most of you remember what was going on up there at that time, this was a horrible time in New York. The ERs were overwhelmed, and a lot of very, very sick people, and probably difficulty taking care of those people. In that population, they had the old troponin assay, and they considered it abnormal if it was greater than 0.03, so that would be 30 picograms per ml, 0.03 nanograms per ml. And using that cutoff, 36% had an elevated troponin I. The elevation was more prevalent in patients who had hypertension or diabetes. The hazard ratio increased with increasing levels of troponin. So if your troponin was 0.03 to 0.09, hazard ratio 1.75 for mortality. If the hazard ratio, if the troponin was more than 0.09 or 90 on the new scale, the hazard ratio was 3. And they also noted that if the troponin was rising during the hospitalization, that also portended an increased risk. If you look at the distribution slide on the bottom left there, so more than 30 would be everything to the right of that second bar, and then 30 to 90 would be that third bar, and then everything else is there. So you can see most people were normal. I'm sorry, this first bar was 30 to 90. The second bar would have been the over 90. So most people had very low levels of troponin, but you do have some who have substantially elevated levels of troponin. And what you can see in the bottom right there is, depending on the troponin level, if the troponin is normal, the likelihood of discharge, which is that dark in the center there, is fairly high. Likelihood of dying is lower. If your troponin is mid-range, the likelihood of dying goes up quite a bit. Likelihood of being discharged home at the time the study was censored is lower. And finally, if you're on the far right there with the troponin more than 0.09, your likelihood of dying is up to 50%. So, in summary, there's a wide variation in detection of myocardial injury depending on the assay you use, the severity of illness, and cardiovascular comorbidities. Troponin elevation and a rising troponin have a prognostic import. HS troponin elevations are common in all sorts of sick populations in the ICU, including those without COVID. So for example, a Mayo Clinic series showed that 42% of those patients with non-COVID ICU patients, this is an older study, were troponin positive. So this is not uncommon in sick patients in the ICU, as any of you who've done cardiology consultations are already aware. So what is the mechanism of the injury? There are several potential mechanisms. First of all, it could be an ischemic insult of some type, either a type 1 event, just a plain old myocardial infarction. So we know that when people are sick and the vessels are inflamed, the plaques are more likely to rupture and the risk of heart attack goes up. This is true for all sorts of viral illnesses and bacterial illnesses. It could be a type 2 MI due to demand ischemia from microvascular damage, hemodynamic stress, microthrombus, DIC, or inflammation. Or it could be some kind of non-ischemic injury. So it could be myocarditis or myocardial injury due to viral infection, direct myocardial injury from the inflammasome or cytokine release, and also could be due to stress cardiomyopathy. So start with the top. What about acute coronary syndrome? So acute coronary syndrome generally is increased 3 to 10-fold in the setting of a viral infection. It could be either a STEMI or a non-STEMI. In terms of STEMI, there are 2 case series we'll talk about, one from New York City and one from Italy. In New York City, they reported 18 patients that they found searching a variety of New York area hospitals who had ST elevation and tested positive for COVID-19. The mean age was 63, mostly male, a large percentage of Hispanics, just because the part of New York City where the study was done. 33% had chest pain, and interestingly, 10 of 18 were found not to have an acute coronary syndrome. This is an example of a ECG from that study. You can see here classic findings of an inferior myocardial infarction with ST elevation inferiorly, ST depression in leads 1 and AVL there, and also in the anterior leads. And you can see the inferior ST elevation actually extends around to V5 and V6. So you might be thinking about a large right coronary artery or perhaps a circumflex. In this particular case, you can see the distal circumflex is obstructed. So this was an ordinary STEMI who happened to have COVID-19 as well. Now, this particular case presented with diffuse ST elevations on the EKG. You can see there's ST elevation here in lead 1 and L most prominently, but also there's some ST elevation in lead 2 and in the anterior leads. And this patient went to the cath lab and had non-obstructive disease, no evidence of infarction. If you magnify up that EKG, you can see there is some PR depression. So this is more of a myopericarditis type picture. So this is an example of COVID-19 causing ST elevation, diffuse ST elevation, and not due to coronary obstruction, more myopericarditis most likely. Now, if you look at this particular study, these two patients, patient 12 had very segmental ST elevation. You can see the ST segments are up in the inferior leads, also in lead 1 here, also in V6. So not a clear coronary pattern, but clearly segmental. This particular patient did not go to the cath lab. The patient had an echo showing normal ventricular function and was thought not to be having a STEMI. Patient on the right, patient 14, had ST elevation in 1 in AVL, and this patient did go to the cath lab, so again, regional ST elevation and no occluded coronary. So these are examples of patients with segmental ST elevation and yet did not have obstructed coronaries, and we have seen examples of this at UAB as well. So if you look at that study, in all there were 18 patients. You can see chest pain was more common in the patients who were having a myocardial infarction, but there were some patients who were having a STEMI who did not have pain and vice versa, so didn't really completely separate out the groups. If it was diffuse ST elevation, that was not likely to be an infarct, but focal ST elevation could be either an infarct or myocardial injury. You can see that a normal ejection fraction was much more likely to be myocardial injury than a heart attack. These patients, it should be noted, were very ill. More than half of each group were intubated, 50% of the injury group were in shock, and if you were not having a heart attack, if this was injury, the prognosis was terrible. 90% of those patients died compared to 50% of the patients with a STEMI. A series out of Lombardy, Italy, found 28, counting left bundle, who had ST elevation or left bundle and COVID positive. Again, mostly male, mostly median age 68. And again, only 39% of those patients did not have obstructive disease at catheterization, despite many of those patients having regional wall motion abnormalities. So again, similar to the New York experience, regional ST elevation does not necessarily mean you're having a heart attack, and many times you can't tell till you get to the cath lab. So in terms of potential mechanisms of injury in COVID-19, clearly type 1 MI, STEMI or non-STEMI is possible, but some other mechanism, whether it's myocarditis or myocardial injury, also seems to account for some of these cases with ST elevation. But this explains, however, only a small fraction of those patients we saw who had troponin elevations. The troponins in the studies I just mentioned were much higher than most of the troponins that were in the Chinese and the Mount Sinai studies. So what is the mechanism of those lower levels of troponin elevation? So 20 to 40% of these patients in very serious have myocardial injury. Most of them don't have acute coronary syndrome or ST elevation. So the mechanism here could be type 2 non-STEMI, so demand ischemia, could be myocarditis or myocardial injury, or it could be Takotsubo. So what is the evidence for this, for these various mechanisms? First, we need to define what myocarditis is. So myocarditis is an inflammatory disease of heart muscle cells, can have either acute fulminant onset with severe LV dysfunction and shock, or a less fulminant onset with either acute or chronic, which may progress insidiously. For definitive diagnosis, you need endomyocardial biopsy or autopsy showing lymphocytic infiltration of the myocardium with myocyte necrosis. So if you see that on your biopsy specimen, then you have a definition of, then you have myocarditis. Nowadays, many times we don't have biopsy information, and we try to make a clinical diagnosis based on the presentation and findings on MRI. And findings on MRI include increased T2, early gadolinium enhancement, late gadolinium enhancement, and native T1 mapping. So it turns out myocarditis is known to be associated with a variety of viral diseases. In some series, some type of virus is found in 25 to 50% of suspected myocarditis cases when you biopsy them. So the question is myocarditis a feature of COVID-19? As mentioned earlier, we know that cardiomyocytes do express the ACE2 receptor. So, we know that if you take cardiomyocytes and put them in, grow them in cell culture, and then put the virus in there, that in that setting, the SARS-CoV-2 virus will infect cardiomyocytes. However, it's been very, very difficult to show that this actually happens in vivo. In fact, I think there's only about 2 cases that I could find worldwide actually showing definitive myocarditis. One was in a child, and then there's one report in a human biopsy specimen. However, in that specimen, the virus was not found in the cardiomyocytes, it was only found in the macrophages. So there's really very little evidence for classic myocardial, excuse me, got to shut that off. There's very little evidence for classic myocarditis in COVID-19. There was an autopsy series of 22 patients that did not find any evidence of myocarditis. However, clinically, these patients were dying from respiratory failure. They didn't clinically have fulminant myocarditis. Most of those patients in that series had mild troponin elevations, but no lymphocytic infiltrate. They had severely dilated right ventricles. And viral particles, interestingly, RNA and viral particles were observed in the heart, but not in the cardiomyocytes. So they were in the endothelial compartment, not the myocytes, and there was not lymphocytic infiltration with myocardial necrosis. So by standard criteria, these patients at autopsy did not have myocarditis. So the authors hypothesized that the elevated troponin in these patients was due to stress from the acute pulmonary disease rather than myocarditis. And one of the things they thought was that, as I said, these particles were observed in the endothelial compartment, and one of the hypotheses is they might be infecting the parasites. So parasites are cells that make up a large component of total cardiac nuclei, up to 10%, and they are known to express high levels of ACE2. So the thought is that it may well be that the parasites are infected directly by the virus. Parasites are highly involved in regulation of myocardial microcirculation. And so one thought is that perhaps parasite infection may lead to microvascular dysfunction and myocardial injury. But none of this has been proved, and nobody's really proven that the virus is in the parasites, just that it's in the endothelial compartment. So in terms of mechanisms of injury, really there's not much evidence for myocarditis. Instead, maybe evidence, those low levels of troponin more likely are due either to microvascular dysfunction, for instance from the parasites or cytokines, or hypoxemia, hemodynamic stress. That would put it firmly in the type 2 MI if it's a blood supply issue, or it could be direct injury to the myocardium from the inflammatory cascade or cytokine release. Finally, a last mechanism of injury is stress cardiomyopathy. This has been observed in 4% of patients in one series, but that also begs the question of what the mechanism is, since we really don't know the mechanism of injury in stress cardiomyopathy, just that it gets better. All right, so you can see there's a lot of evidence that there's myocardial injury in COVID-19, sometimes severe. Many of these people have severe left ventricular and or right ventricular dysfunction. There remain a lot of important unanswered questions. I think maybe for many people, myocardial injury, they're so what? That's not really what they care about. You know, the important unanswered question, the elephant in the room, so-called, is it safe to play football? I mean, that's really what everybody wants to know. So, is it safe to play football? There was a study in Germany in around springtime that kind of got everybody very upset about this issue, and this is kind of the study that canceled Big Ten football, or at least postponed it for a while. So this study, there were 100 patients, mean age 49 years, 53% male. And what they did is they recruited these patients who had recovered from COVID, no longer were having symptoms. These were not patients who were referred for symptoms. These were just patients who were in a registry in Frankfurt with COVID and agreed to participate in the study. The MRI was done an average of 71 days after diagnosis. Of these patients, 2/3 actually had been managed at home, never been hospitalized. 17% had atypical chest pain, 36% had dyspnea. At the time of the study, which again was 71 days after on the diagnosis, troponin was detectable with more than 3 picograms per ml in 71%, but only abnormal, that is more than 99th percentile, in 5% at the time of the MRI. So most of these patients did not have evidence of active ongoing myocarditis at the time of the MRI, or I shouldn't say myocarditis, myocardial injury at the time of the MRI. Now the thing that got everybody's attention with this study was the main finding, which is, quote, 78% had evidence of cardiac involvement by MRI. Additionally, what was very concerning is 3 of these patients appeared to have severe abnormalities and underwent biopsy, which showed lymphocytic infiltration. Did not show myocyte necrosis, so again, did not meet clear standard criteria for myocarditis. But certainly something was wrong with these hearts. And again, these patients weren't that sick compared to many series. So the diagnosis of abnormal was made by cardiac MR based on either a raised native T1 or T2, late gadolinium enhancement or pericardial enhancement. And what the authors reported is that one or more of these abnormal findings was more frequent in COVID patients than age risk factor matched controls. So without getting into the details of this too much, I'm showing you some of this data just so you'll see how much overlap there is between groups. So on the far left in each of these slides is healthy controls. So there's the normal native T1, normal native T2, and of course undetectable, typically high sensitive troponin. In the risk factor match controls, you can see those abnormalities are all much more prevalent than in healthy controls, so there's a difference there. When you look at the COVID-19 home group, you can see there's an awful lot of overlap with risk-matched controls. Nonetheless, up at the top, you can see there are some cases that seem to be fairly far out, several standard deviations different from even risk factor matched controls. And same thing with the COVID hospitalized patients. So there are patients up here that don't seem to be within the normal range for risk factor matched controls. As for native T1, similar findings for native T2. In terms of the high sensitivity troponin, you can see that, as I mentioned earlier, a small number of patients who are abnormal, which was not seen in the risk factor matched controls. So, findings from this study: a significant percentage of middle-aged Germans have at least some abnormality on MRI 2 to 3 months after COVID infection. However, so do a lot of risk and age-matched controls. The abnormalities do seem to be more prevalent in patients who were initially hospitalized, but are also seen in patients who were treated at home. So that's particularly concerning when you have a patient group that didn't really seem to be that sick and yet might have an abnormality on the MRI several months later. Everybody's very concerned about what that might mean. Severe abnormalities were also seen in patients without COVID who were age-matched controlled, but smaller amount. And one patient had minimal symptoms and yet had severe abnormalities. So the question is, what does all this mean in terms of anybody's risk for instance, returning to competitive sports? There were some alarming reports at the same time going on in the lay press. There was a baseball pitcher, Eduardo Rodriguez, who got some kind of a myocardial injury syndrome and reported he felt like he was 100 years old. He ended up missing the 2020 abbreviated season. There was the case of Michael Ojo, an international basketball player who went back to training shortly after recovering from COVID and died suddenly. We don't really know whether he died arrhythmia sudden death, pulmonary embolism, or something else. He collapsed on the court while training and died. And then finally, around the same time, there were a lot of reports in the lay press about a 35% incidence of myocarditis in Big Ten athletes post-COVID. And at the time this German study came out, the study of the Big Ten athletes hadn't been published yet. So all this raised a lot of concern, and the Big Ten responded by saying they were going to postpone their season. And what happened next? Well, what happened next is a cardiologist from Mayo Clinic, a sports cardiologist named Michael Ackerman, said that he didn't really think that middle-aged German study was particularly relevant to 20-year-old athletes. The lay press responded that if we have college football this fall, Dr. Ackerman will be one of the reasons why. And he said that the study that sparked a panic across college sports didn't have the, quote, bandwidth to be transferable in a useful way, and said it was a scientific foul to infer that those findings are relevant to 18 to 24-year-olds. So as a result of that, I have a picture of Dr. Ackerman here being inducted into the College Football Hall of Fame. So anyway, that did prevent Big 12 and SEC and other conferences from canceling their seasons. And they went ahead and started just with decreased schedules a little bit late. And meanwhile, the Big Ten was still considering what to do when this study came out. And so this is the Ohio State. They finally published the data about the athletes there. So they had a CMR exam of 26 competitive athletes from a wide variety of sports who were referred to the sports medicine clinic between June and August, a meeting of 23 days after testing positive for COVID-19. So these are young patients, and as you expect, they weren't very sick. 12 had mild symptoms, 14 were asymptomatic. An EKG and troponin were all normal when done on the day of the CMR. We don't know what it was at the time of their diagnosis. Again, this was done 3 weeks later on average. What was concerning about this study is that the authors reported that 12 of the 26 athletes had late gadolinium enhancement. Now, in 8 of those, that was without an elevated T2. There are criteria for probable myocarditis clinical diagnosis called the Lake Louise criteria. So 4 of these athletes had CMR findings that met the Lake Louise criteria. That is an increased T2 and late gadolinium enhancement. 2 of those 4 had mild shortness of breath. The other 2 were asymptomatic. So the concern was, did this mean these patients or athletes had myocarditis or myocardial injury of some sort despite having minimal or no symptoms? Which, if that's truly what's going on, would be very concerning about, what kind of risk are these people at, even if they're asymptomatic. Limitations of this study was that there was no control group and a variable time between infection and MRI. And we don't really know what the significance and risk of a low level of asymptomatic, really shouldn't say myocarditis, but low asymptomatic myocardial injury in this population is. So the question is, based on all this, what did the Big Ten do? Did they say, well, we were right all along, we're not going to play football, it's too dangerous, these people have this, that, and the other thing? Well, it turns out not. So the Big Ten went ahead and decided they're reversing course, they're going to start playing in October. And ironically, that announcement came out about 3 days after the study was published. So they eventually decided that if they did a lot of testing, that their athletes would be safe. So what they're doing in the Big Ten is a fairly aggressive approach. They're doing daily antigen testing. If you have an antigen test positive, that gets confirmed with PCR. If you're positive, you can't participate in sports for 21 days, and you need to have a troponin, echo, and cardiac MRI, and clearance from a cardiologist before you come back. Now, that is a very aggressive approach. Whether CMR is necessary remains uncertain, and what to do with CMR results remains uncertain. So what did the guidelines say about this? ACC guidelines on returning to sports after COVID-19. So if you're COVID-19 negative and asymptomatic, exercise training is fine. If all COVID-19 positive patients need to refrain from training for 2 weeks. So if they're asymptomatic, you would, from the time of your diagnosis, you have to wait 2 weeks before considering a return to play. And if you remain asymptomatic over that 2-week period, you can have slow resumption of activity. What about patients who are symptomatic? If your symptoms are mild to moderate, what's being recommended is an examination, an echo, and a troponin 2 weeks after you're asymptomatic. And depending on the results of that, some patients may be referred for exercise testing, CMR, or ambulatory rhythm monitoring. If you're hospitalized with normal imaging and a normal troponin in the hospital, what's recommended is a cardiovascular exam and considering cardiac retesting before resumption of exercise. All that would have to wait at least 2 weeks after the last symptoms. And finally, if you're hospitalized and you have an elevated troponin or other evidence of myocardial injury, such as myocardial dysfunction by echo, it's recommended that the myocarditis guidelines be followed. Now again, these patients probably don't have classic myocarditis, but nonetheless there is concern, and it's recommended we follow the myocarditis guidelines, which basically says no vigorous exercise or training for 3 to 6 months. At the end of that time, you retest, look at ventricular function and troponin, do a halter or treadmill, make sure there's no arrhythmia, and if those things are normal, then you can resume exercise at that point. And it's clearly athletes who have probable definitive myocarditis should not participate in competitive sports. That's the myocarditis guidelines. We have much less information for the troponin myocardial injury that we see in COVID-19 to know what's safe for those athletes. In kids, the guidelines are somewhat similar, although they're a little looser. So in children who are positive, it's recommended that they wait 2 weeks. If they're asymptomatic, then they can return to play. If they're mildly symptomatic, no fever, less than 3 days of symptoms, again, 2 weeks after resolution of symptoms, they can resume all activities. If they're moderate symptoms, that's defined as prolonged fevers, bed rest, without hospitalization. If they're aged less than 12, again, they would return 2 weeks after symptom resolution. If they're more than 12, it's recommended that an ECG be done. The guidelines say if the ECG is okay, they can return to sports. If not, they should probably see a pediatric cardiologist, consider a troponin or imaging. And then there is a severe syndrome in children called multisystem inflammatory syndrome, which is sort of reminiscent a little bit of Kawasaki. So those children, we follow the myocarditis guidelines, and they're out for 3 to 6 months and need a lot of testing before they can come back. And that also applies to children with lesser degrees of cardiac injury, either troponin elevations or abnormal ventricle. Moving on to arrhythmias. So arrhythmias are seen in COVID. In one series out of China, there were 6%, 5.9% malignant arrhythmias, more common in those with myocardial injury. usually non-shockable rhythms like asystole and PEA. So for the most part, these likely were patients who were critically ill in the ICU. Italy also reported an increased risk of out-of-hospital arrest during their pandemic. It's unclear if these arrests were due to COVID patients or other patients with a variety of cardiac problems who were afraid to go to the hospital or couldn't get in because Italy was having such a problem at the time with overwhelmed ERs. And again, in various series in this country as well, most of the hospital wrecks are due to non-shockable rhythms. And a recent study demonstrated basically 0% survival to hospital discharge in patients suffering an in-hospital cardiac arrest. Atrial fibrillation has also been reported in 19% of patients in Italy and also in Mount Sinai, and seems to be more frequent in ICU patients. This is similar to what we see with other critically ill patients and probably not specific to COVID. There is an increased risk of coagulopathy with COVID-19. So COVID-19 patients who are very ill often have elevated D-dimer and elevated INR. It's unclear if this is DIC versus some kind of complement-mediated microangiopathy. Thrombotic microangiopathy of the lungs has been reported, and less commonly that has been reported in other tissues in autopsy series. In one Dutch study of patients in the ICU, there was an incidence of thrombotic events of 49%, mostly pulmonary embolisms, but also some strokes and systemic arterial embolisms. In one case series out of New York City, 1.6% of patients with COVID-19 either presented with a stroke or developed stroke in the hospital. This is higher than we typically see with other viral illnesses, for instance, with influenza. Most of the patients who get this are older and have underlying risk factors for stroke, but there is a troubling incidence of stroke in young patients, and in some young patients, especially young men, stroke may be the presenting symptom and can be quite devastating. In terms of pulmonary embolism, as I mentioned, it's very common in hospital. However, there has been concern about whether there might be increased risk of pulmonary embolism once you go home. There was a case, one of my colleagues working in Alexander City here reported where one of his patients survived the ICU, did great, went home and was back in a couple of days with a huge pulmonary embolism. There's one study looking at this out of the United Kingdom, and they saw 4.8 pulmonary embolisms per 1,000 hospital discharges, but it was not different from the historical rate for medical discharges. So currently, routine post-discharge anticoagulation is not recommended unless your patient, has risk factors or has known thrombotic disease in hospital. However, the study out of the UK did not identify high-risk groups. And this is a picture of I found something called livido racemose. You can sort of see this mottled purplish skin rash there in the feet. And it turns out if you have that, it's due to thrombogenic vasculopathy, so occlusion of a vessel there. And the 4 patients in this series who had that all had pulmonary embolism despite prophylactic level anticoagulation. So if you see this thing in your ICU patients, you probably want to be looking for venous thrombosis and anticoagulating them. In terms of medications, several common cardiovascular medications have been of concern with COVID. So first of all, the ACE inhibitors and angiotensin receptor blockers. Both of those drugs upregulate ACE2 receptors, and the concern early on was that it might increase the risk or severity of infection by ending up with it making more receptors for the virus to infect cells. On the other hand, there's potential benefit to upregulation of ACE2 because it may decrease the severity of ARDS in animal models by offsetting some of the vasoconstriction. So the actual data we have is all retrospective, and there doesn't seem to be any difference whether a patient was on an ACE and ARB or not when they got in the hospital, whether it was continued or not. So the current recommendations are if you have an indication for an ACE or an ARB, you should continue it, but you shouldn't start an ACE or an ARB trying to decrease the risk from COVID. In terms of anticoagulation, prophylactic dose heparin is recommended in hospitalized patients because of the thrombotic risk. There are some retrospective studies suggesting a possible protective effect of statins. And there are ongoing studies looking at colchicine. So colchicine is anti-inflammatory, and there's animal data that it might be beneficial in mitigating cytokine storm. There was one small open-label trial, I think it was out of Greece, showing faster recovery and lower biochemical endpoints if you used colchicine. However, the trial was small and open-label, so it's unclear how effective colchicine really is, and there are larger studies in progress looking at this. The other issue with cytokine storm is that there's a thought out there that maybe the severe injury to the heart that happens in this disease, that the heart and the rest of the body, is not cytokine storm so much as bradykinin storm. There's some evidence for that, and bradykinin might explain some of the deposition we see in the lungs of hyaluronic acid. So in conclusion, primary or secondary cardiac complications are common in hospitalized patients with COVID-19. Myocardial injury is highly prevalent in hospitalized patients. There are for sure ischemic mechanisms and likely non-ischemic mechanisms as well. Takotsubo has been reported. The virus RNA has been demonstrated in the heart at autopsy and by biopsy, but when electron microscopy has been used to look for the viral particles, they're mostly in non-cardiomyocyte cell lines, either macrophages or parasites. RV failure is also common in the autopsy series, where these patients are dying of lung disease and cor pulmonale, and this may account for many cases of myocardial injury in the ICU severely ill patients. MRI studies have shown a concerning prevalence of abnormalities after recovery from COVID, including outpatients, sometimes with few symptoms. But the clinical significance of these findings is uncertain at present. The long-term consequences of COVID-19 in terms of putting you at risk for cardiomyopathy or long-term problems is currently unknown. However, as I mentioned earlier in the talk, we've had 32 million cases worldwide to date, and so far there's been no epidemic of late sudden death or cardiomyopathy as far as we know. So hopefully there won't be long-term sequelae, at least to the heart, although there clearly are some patients who continue to have chest pain and a lot of dyspnea weeks and sometimes months after infection. Finally, thrombotic complications are a prominent feature of COVID-19, and if you're hospitalized in the ICU, the risk of pulmonary embolism is fairly high. Thank you very much for your attention today. I guess it's not simple for you to send me questions, so I'll just sign off. Thank you.